Hi, this is Chris. Welcome back to Basic EKG Interpretation for the Healthcare Provider. We are going to go over Chapter 5, Atrial Rhythms now. A quick reminder of the 5 rules. And so an atrial rhythm is not sinus or not consistently occurring with a stimulus from a sinus node. So somewhere in the atria. All right. A pacemaker can wander, or a single stimulus can occur from one individual location, and you get different variations that can show up on an electrocardiogram, and we're going to go through those right now. All right. So with a wandering pacemaker, just kind of think of your stimulus kind of like wandering around up there, or you can have a single irritable focus. All right. So let's talk about the wandering version. So the first rhythm that we're going to discuss is the wandering atrial pacemaker. So go through your 5 rules, measure your rate and regularity. So we're going to check to see if this rhythm is regular, kind of going across. You can see it starts to tighten up a little bit. Really, for the most part, this is a regular rhythm though. All right, so we get a rate of 60. We got 25 boxes in between those R intervals until we get to the purple one, which is 24. So it is slightly irregular. And then you do have P waves that are varying in shape, and that's what distinguishes this rhythm from a sinus rhythm. So if you look at these P waves here, they're nice and round and upright. And then you have P waves that are kind of starting to flatten out and carry a different morphology than the ones at the beginning of the complex. So we have a wandering atrial pacemaker. And then if we measure our PR intervals, they vary as well, which is a common characteristic of these wandering atrial pacemaker rhythms. Our QRS width is not wide. It's not equal to or greater than 0.12 seconds, but it is 0.10. You can kind of see that with the naked eye that we're about 2.5 boxes wide. All right, so we're going to call this a wandering atrial pacemaker. All right, if you do have a rhythm like this that is faster than 100, the nomenclature, the wording that you're going to use is multifocal atrial tachycardia. If you think of the wording, you're getting multiple foci of the atria with a varying shape in the P wave. So it makes sense. But you would never say a wandering atrial pacemaker tachycardia. You word it like as indicated on the screen there. So the next rhythm that we're going to discuss is a premature atrial contraction. In the subsequent chapter, and then in chapter 7, we discuss premature junctional contractions and premature ventricular contractions. So this is a situation that occurs when you have a early complex in your rhythm strip. So let's look at what this looks like when we start with our 5 rules and measure regularity. We can see our distances there are identical. All right, and our distances with those two larger calipers is also identical. So I identify this as regularly irregular. And if we're not counting that first complex over there, the rate is 60. Because it's irregular, I'm just counting the complexes and adding a 0. So if we measure our PR intervals for the underlying rhythm, they are all identical. All right, so the PR intervals are all the same. It indicates that this rhythm has an underlying sinus rhythm. Okay, but we do have these early beats that are coming, and we know that these early beats are atrial in nature because there is a P wave there of different morphology. You can measure the PR interval there. I kind of have that in a green. It's not common. You wouldn't really record it, but it doesn't hurt. So moving on to our QRS width of 0.08, which is less than 0.12. So that's a normal QRS width. So we identify this rhythm as sinus with PACs. There's 2 premature atrial contractions, or actually 3. All right, so sinus with PACs is how we can interpret that one. So next we want to talk about fused beats. All right, so when a P wave and a T wave overlap, it results in fused beats. And what does that mean? So the morphology of a P wave and a T wave that come together can look like a triangle. A lot of times it'll be more rounded. Sometimes it'll be round with a notch in it. And so essentially you're changing the morphology, and you can't really measure the PR interval because you don't know where that P wave starts. And you don't know, sometimes you don't know if there's a P wave there at all. Is it just a T wave? So why am I explaining that to you? So with supraventricular tachycardia, you have remember tachycardia is faster than 100, but with SVT, with a supraventricular tachycardia, we're talking about beats that are faster than 150. All right, so let's go through our 5 rules and measure the regularity. And you can see our distances all the way across are 6 small boxes. So we multiply that into 1500, and you can see we get a rate of 250, which is moving along. That's a very fast rhythm. And so it is regular. Our P waves are not discernible. You're not going to measure a PR interval in this case because of it being a fused beat. All right, you can measure the QRS width and should. And so when we get all of those together, you get an interpretation of supraventricular tachycardia, all right, or SVT. All right, so moving on to no measurable or discernible P waves, and the 2 choices that we have here is atrial flutter. Sometimes flutter waves are called F waves for short, and then you have atrial fibrillation over there. So let's start with atrial flutter and just kind of understand that you're getting F waves that all look the same. So we're talking about an irritable foci that's coming from one spot in the heart. Sometimes this can be because of what's known as a re-entry mechanism. So this would be AV nodal re-entry. In some patients, they might have a heart defect where you can have a re-entry mechanism occurring somewhere else where the ventricles and atrium meet and have an accessory pathway. So these things are uncommon, but we see them enough that it might be something that you come across as a paramedic or a nurse. All right, and then moving into atrial fibrillation, you can see in this case you're getting foci from all over the place in the atria. All right, so it's chaotic, it's a mess, and you're getting a unorganized conduction in the atria, and it results in a fibrillatory pattern. So the blood tends to pool at the top of the heart. It's not being kicked from the top of the bottom efficiently, and therefore, people with atrial fibrillation are at risk for throwing clots. And they are often on medication to reduce that risk of them having a heart attack or a stroke or something else, some other type of event that results from clots flowing through the body. So with that, if someone is on these medications and they have a traumatic incident, you have to worry in those cases about them bleeding to death. All right, so let's take a look at atrial flutter and go through our 5 rules. Remember, these rhythms can be regular or slightly irregular. And so let's look at our regularity here going across. These are all the same distance apart, about 20 boxes apart, giving us a rate of 75. So it is regular. Our P waves are a flutter or sawtooth pattern, so they're not measurable PR intervals. So again, we just put an X over that. Our QRS width is 0.08, so we interpret this as atrial flutter. And very quickly, slightly irregular. If this QRS complex was followed by 2 of these flutter waves and this one came early, it would indicate a 3-to-1. So for every 3 of those flutter waves or F waves, you're getting a complex. But this rhythm is a straight up 4-to-1 all the way across, so it is regular. All right, with atrial fibrillation, when you go to measure the regularity of this one, you'll see that it's all over the place. So if we have this caliper, then you can see a very wide distance, and then it gets narrow again, wide again, kind of somewhere in the middle. So it's irregularly irregular. There's no rhyme or reason or pattern to it. Because of that, we can't measure PR intervals. There's no discernible P waves. So it's just kind of a fibrillatory pattern that doesn't have obvious P waves. Don't be confused by these. Those are T waves. You can see you do have organized T waves, which is representative of ventricular repolarization after the QRS complexes. And when you have atrial fibrillation that's real fast, a lot of times you see those T waves, and it's hard to tell the difference between atrial fibrillation with what we call RVR, or rapid ventricular response, from SVT. That's why it's really important to measure out that regularity across. So in this case, we have atrial fibrillation.